Just a little bit of background. My research is in pain and analgesia, so the last more than 10 years or so I've been investigating new drugs for the treatment of pain. And of course I'm in the life science department, so I come across some optometry students now and again, but I don't suppose I've met many of you before. So what I thought I'd do this morning, pain management and pain is such a massive, broad topic. It's quite difficult to fit it in a 50-minute lecture. But because it's Sunday morning at 9 o'clock, I thought I would keep it quite general and just a bit more interesting. So I've got a couple of little video clips for you, and what we'll do, we'll start with an overview of how we perceive pain. So a little bit of physiology, a little bit of anatomy. So it's important to know where the pain comes from, how do we perceive pain, and then the second half of the lecture will cover some of the core drugs that we use to treat pain conditions. So some of the details of the pharmacology are in the documents that you've got in your handouts. So rather than me telling you all the mechanisms and listing drug after drug, which is quite boring for pharmacology, I'll keep it quite general towards the end. Okay? So why do we need pain? Why is pain important? I mean, all of us will have experienced pain at some point in our lives, and we know its value, it's protective. Without pain, people don't survive. And we see this in a condition known as congenital analgesia, or congenital insensitivity to pain. So I've got a little video here just to show you why we need pain and why it's important.
There are many rare diseases in the world. A 12-year-old girl, Ashlyn Blocker, suffers from an exceptionally bizarre genetic disorder and has a congenital insensitivity to pain. Simply put, she can feel absolutely no pain whatsoever. The disorder is very dangerous because the inability to feel pain means that sufferers may not recognize a potentially deadly problem as the warning signs cannot be felt. As an infant, Ashlyn never cried. Then, at 8 months, her parent took her to the doctor for an irritated eye. Medical staff noticed that she had a corneal abrasion which should have been very painful. That visit led to multiple tests, and almost 2 years later they received a diagnosis. To this day, Ashlyn will still sometimes stick her hand in a pot of boiling water to fish out a dropped utensil, forgetting that it will cause her skin to burn even though she won't feel it. Serving as an inspiration, Ashlyn and her family have started Camp Painless But Hopeful, a camp designated to raise awareness and help families living with congenital insensitivity to pain.
Sufferers from this condition have a mutation in a particular receptor, a sodium channel receptor, which means they don't feel any pain. So what happens quite often, as you see from the video, they can end up with life-threatening injuries. Pain is protective. If you've got an internal infection or a disease, quite often you have pain. It's a warning sign to say there's something wrong with my body, there's something wrong with me. Quite often, again, if you've sprained your ankle's tender, so when you walk on it, it protects you from further damage. So these are all really important things why we feel pain. So, as I say, it assists in repair and healing, and it protects from further damage. Now, not all pain is protective. When it comes to chronic pain, we'll see, and nerve injury pain, quite often this is called dysfunctional pain, and it doesn't have any evolutionary advantage. So there's some distinctions between the types of pain that we need to understand, and this is important when it comes to pain management. You need to know what the cause of the pain is, what the source of the pain is, before you can then decide what type of drug or what kind of medication that you would prescribe to treat the pain. So I'm going to do a little overview of the 3 types of pain. I've got nociceptive pain, inflammatory pain, and then finally chronic pain. So I'll show you later on as well some of it's called the pain neuroaxis, how pain is perceived in the periphery and how it's then transmitted to the brain. I've got a nice little video to show you to illustrate that. But what we've got here is the first type of pain is nociceptive pain. So this is the type of pain that if you banged your hand or your elbow off a table and you have a quick withdrawal reflex, again it's protective. So what we have here, we have the nauseous stimuli, and this can be either heat, so intense heat, cold, intense mechanical force, or a chemical irritant. So something like capsaicin from a chili pepper or acid would cause a activation of the nauseous fibres, activation of our nociceptor. Now these nociceptors are specialised receptors that only perceive pain. Once they're activated, they transmit information up to the spinal cord region, and in particular this region here, which is called the dorsal horn region of the spinal cord. And it's here where we get the withdrawal reflex. There's a nerve fibre that transfers over to the motor neuron and causes this reflex to stop further damage. So the little girl that didn't have any feeling to pain, the congenital insensitivity, she puts her hand in boiling water, she doesn't sense any pain, so therefore she doesn't have the withdrawal reflex. Okay, so this is a protective function. In terms of nociceptive eye pain, the most common cause of this would be some kind of mechanical force or damage. It can be induced by chemical stimuli as well, as we'll see. This triggers a number of stereotyped behaviours. For example, you see people like rubbing their eye or blinking and tearing of the eye. So this is a basic nociceptive response. It doesn't tend to persist for a long period of time, and generally this type of pain wouldn't require any treatment. But it's when we go back to see our inflammatory pain, this is when quite often it can persist for a bit longer and can be associated with long-term hypersensitivity. So again, you've got some handouts in your pack, and I think there's an article on inflammatory pain and some details of the anti-inflammatory drugs that we use. But really, what happens with inflammatory pain is this is associated with tissue damage. Okay, so we get tissue damage. It could be a scratch in the cornea. It could be induced by infection. And this involves the recruitment of immune cells and inflammatory mediators to the site of the damage. So we get macrophages, mast cells, neutrophils, granulocytes. These are all recruited to the site of the injury. And they release a whole host of inflammatory mediators. Again, there's a slide to illustrate this. There's bradykinin, serotonin, prostaglandins. And what they do is they cause a sensitization of the nerve fibre. So this is our peripheral nociceptor. We get activation of this nociceptor, causes the nerve to fire action potentials along the nerve root up to the dorsal horn. You get spontaneous pain and pain hypersensitivity. So what happens when you touch the area that's sensitive or the area that's inflamed, there's a hypersensitive response, there's an increased reaction to the nauseous stimulus. So this is a little bit more detail then of the inflammatory response. Some of the key mediators that are released in response to tissue damage. Some of the ways that we might induce inflammation are listed here in the pink box. So again, foreign body, some abrasions, lacerations, surgery, infection, conjunctivitis. These are all things that are associated with the inflammatory response. They cause release of inflammatory mediators at the site of damage, which then activates the peripheral receptor, which is our nociceptors, sends information up towards the spinal cord, where you get activation of the spinal cord response. The next phase is transmission of information up to the brain, which I'll show you in a second. So how does the actual eye perceive pain then? So I've been talking about these things called nociceptors. So these are specialised receptors that only respond to nauseous stimuli. But there are other receptors that can be activated in response to external stimuli. And in the surface of the eye, we have 4 different receptors. If you look at the box here, this is this type of stimuli that activates a particular receptor. So we have a mechanoreceptor, as the name suggests, that responds to mechanical stimulus. So it responds to touch. Now this can be innocuous touch, so just like a gentle touch, or it can be nauseous touch, which is more intense mechanical stimuli. So if you get a punch in the eye, it's going to induce nauseous mechanical receptors, not the innocuous ones. But in response to inflammation, what happens sometimes is that even when the innocuous fibres are activated, that also induces a pain response. And that's the thing called hyperalgesia or allodynia. So these are clinical characteristics of the inflammatory response. So we've got our mechanoreceptors, we also have polymodal receptors. Polymodal means they respond to different types of stimuli, so they can respond to heat, chemical irritants, or bacterial toxins. We also have receptors that respond to cold. So these channels here are particular receptors that only respond to cold stimuli. So that's how we would then perceive the pain response. So they activate the receptors, which then induce these particular types of pain in the eye. So the third type of pain then is pathological pain or chronic pain. This is different from the inflammatory pain in that it doesn't really have any adaptive benefit. Quite often the chronic pain will persist even after the tissue injury has healed. So if we're talking about just general pain conditions, common chronic pain conditions would be things like back pain, or nerve injury pain is the other type of chronic pain. So when we're looking at the chronic pain, we're thinking here we've got peripheral nerve damage, or it can be central nerve damage. And this is often associated again with pain hypersensitivity, but is maladaptive. So it doesn't have any advantage to the system. It doesn't protect us from any further damage. Okay. So in terms of ocular pain or eye pain, examples of quite commonly induced chronic pain would be things like trigeminal neuralgia. We also have neuritis, which is inflammation of the nerve. So for example, you can get inflammation of the optic nerve that can cause chronic pain. And post-herpetic neuralgia. So post-herpetic neuralgia is linked to inflammation of a particular nerve, and it's induced from activation of the chickenpox virus. So you'll have heard of shingles? Yeah. So shingles is a condition where the chickenpox virus resides within a particular, it can be a cranial nerve or it can be a spinal nerve. And when it's reactivated, it travels down the length of the nerve and erupts in the surface of the skin. So that's shingles. But what happens, even after the spots disappear, people can still have a hypersensitive reaction to the virus. So because it induces inflammation of the nerve, and then the spots disappear, but the person is still hypersensitive to the area of touch. And it can persist for months after the condition disappears. So it can occur in the spinal nerves, but it also occurs in the cranial nerves. So quite often people can get shingles and post-herpetic neuralgia around about the face and the trigeminal nerve. So you'll see from this little diagram here is an example of trigeminal neuralgia pain. So the fifth cranial nerve, and again I've got another diagram to show you some of the cranial nerves, so it's quite nice. But the fifth cranial nerve is split into three branches. The first branch of the trigeminal nerve is ophthalmic nerve. The second is the upper jaw, and the third is the lower jaw. An inflammation or damage to this nerve can induce pain in the ophthalmic region. This particular example is showing vascular compression. So it's like a swelling of the blood vessel, compresses the nerve, and that's what induces the pain response. So let me just go back there, and I just jumped forward a wee bit, just to give you some of the definitions of neuropathic pain, that it can be peripheral, and it can be central. Examples of lesions in the central nervous system that would induce chronic neuropathic pain include stroke, tumour, disc lesion, or even infection. Examples in the peripheral nervous system that can cause chronic neuropathic pain include nerve entrapment or nerve damage, amputations, but also infections or metabolic disease. So things like diabetes can cause neuropathic pain and nerve damage. People with diabetes quite often develop a neuropathic pain early on, but then as the condition progresses, the nerves can degenerate and then they become almost insensitive to pain. So there's two phases of diabetic neuropathy. So some of the manifestations of chronic pain then are shown in the slide here. So there are positive symptoms and negative symptoms. To see the negative symptoms are more associated with prolonged neuropathic pain. So you get numbness, sensory impairment, and that's when the nerves actually start to degenerate. At the early phase of the chronic pain, you get alterations in sensory perception. So you get things, burning pain, electric shock-like pain, paresthesia and dysesthesia. Paresthesia is this pins and needles type pain, and dysesthesia is an abnormal sensory perception. So the person feels it's not a painful response, but there's something abnormal in the way they perceive touch. Allodynia is an increased sensitivity to innocuous stimuli. So a good example of that would be, and probably a lot of us will have experienced it, is if you've ever had sunburn. So normally if you stand in the shower at, say, the temperature's 40 degrees, there's no pain perception, but if you've had sunburn on your shoulders and then you stand under the water at the same temperature, it can induce a pain response. Now that's the perception of pain to a normally innocuous stimuli, and that's what allodynia is. And in things with like post-herpetic neuralgia, allodynia is a clinical problem. So again, and even trigeminal neuralgia, if you just touch the surface of the skin, it induces an abnormal pain sensation. So that's allodynia. Hyperalgesia. Have you heard of hyperalgesia? Have you come across that? That's an increased sensitivity to normally nauseous stimuli. So these are all features of inflammatory pain, but mainly chronic neuropathic pain or neuritis. Okay, so before we go into more of the anatomy then, I've got a lovely little animation here that helps to explain the pain pathway.
Nociceptive pain. Nociceptive pain occurs as a result of the activation of the nociceptive system by noxious stimuli, inflammation, or disease. Nociceptive pain proceeds through 5 phases: transduction, conduction, transmission, perception, and modulation. Nociceptive pain originates in the nociceptors, which are highly specialized primary sensory neurons found primarily in the skin or joints or the walls of organs. These receptors convert noxious stimuli into electrical current through a process called transduction. The current is then conducted along the nociceptor axons to their cell bodies, located in the dorsal root ganglion in the spinal cord, and then to their central terminals located in the dorsal horn. Here, the electrical impulses initiate neurotransmitter release from nociceptor central terminals, which relay the signal across synapses to the dorsal horn neurons. Greater stimulus intensities are associated with the release of neuropeptides, including substance P, from central terminals of C fibers. Substance P, acting via neurokinin receptors located on dorsal horn neurons, generates a greater postsynaptic response and enhances the activity of NMDA receptors. The signal is then relayed via ascending nociceptive pathways to higher centers in the brain, where it is perceived as pain. Ascending nociceptive transmissions are modulated by inhibitory or facilitatory control systems in the dorsal horn of the spinal cord. The process of inhibition and facilitation is regulated by neurons projecting from the nucleus raphe magnus in the lower brainstem. Nociceptive signals are transmitted through descending projections in the dorsal horn of the spinal cord. Facilitation serves to provide warning of tissue injury and encourages protective behaviors, such as fight or flight responses, while inhibition may serve to provide analgesia at times of danger so that pain does not compromise function.
So the little video covered conduction of the nerve up to the spinal cord, and then up to the brain we have perception of the pain, and then we've got descending modulation. So what exactly is that? So this is a really nice simple little cartoon showing how the brain is where we perceive pain. So if you chopped off your head, you would still have the nociceptive reflex, you would still withdraw from the boiling water, but you wouldn't feel it as painful. Well, you might not be alive, but if you severed your head. So the brain it's not until it gets to the brain where we go, ouch. Okay, so that's and there's a whole different number of regions in the brain that actually cause this response to pain. And the scan here just shows some of the areas of the brain that are activated in response to a nauseous stimuli. So this was just a brain scan. You can see the different planes that have been analysed in the scan here. So it's all very well talking about the spinal cord. The spinal cord is where we perceive pain from our peripheral organs from here down. What about the eye? So you know the eye is innervated by cranial nerves. So what we've got here is a little picture of the brain here. So here's our spinal cord. And the spinal cord, at the top of the spinal cord, we've got this region called the pons and the medulla. And it's within this region here where the cranial nerves actually innervate. So if we sectioned through this part of the pons, we would see the area where all the cranial nerves innervate. Now what we've got here is a lovely diagram. It's quite detailed, this diagram, but it's really to show where the cranial nerves innervate. So here you've got the spinal cord level, and if we sectioned through the spinal cord, through the pons, and then right up to the cortex here, you can see where the sensory nerves innervate. So the red fibres here are pain and thermal sensations. The blue fibres are tactile or pressure sensations. So you can see in the spinal cord it innervates the dorsal horn region and projects up through the medulla. So this part here is the pons, up through the midbrain, and then finally where it terminates in the somatosensory cortex, and that's where we perceive the pain response. So the facial nerves, like the eye, the nose, the ear, these all innervate slightly higher up. So we've got, it's hard to see here, but this will be our trigeminal nerve innervating the pons. But it works in the same way. It then projects up to the brain where we perceive the pain response. And here's our 12 cranial nerves here. I think this is a really nice diagram to illustrate how the cranial nerves innervate the pons area. So again, we're looking up at the base of the brain here. So here we've got, this would be your spinal cord innervating the pons and the medulla. And you can see the 12 cranial nerves. But the ones that we're interested in, and the ones that transmit ocular pain, are highlighted here. So we've got the optic nerve, the trigeminal nerve, and the facial nerve. So these are the pain, where the nerves where pain could be transmitted through. And again, as I mentioned earlier, the trigeminal nerve is divided into 3 branches, and it's the first branch that transmits pain from the cornea and the iris. So what influences our pain perception? So the cranial nerves innervate the pons and medulla and then transmit information up to the brain. Now, there's a whole other hour's worth of material to describe why different individuals perceive pain differently. And it could be due to your previous experience of pain, it could be due to your mood, it can be due to your ethnicity, it can also be due to your gender. So all these things can have an influence on how people report pain and how they actually respond to pain. So got a question for you, and we'll focus on gender because it's always quite interesting. So there's obviously a difference between the way males and females perceive pain and respond to pain. So I want you all to raise your hand. Okay. So I want you to put your hand down if you think males are more sensitive to pain. Ooh, interesting. Well, actually, quite a lot of you did put your hand down, which is wrong, I'm afraid. Unfortunately, females are more sensitive to pain. So I know we've got a perception that males sometimes complain a lot, but that's, you know, complain. So it's unfortunate. Females have more chronic pain conditions. Females suffer from migraine more, they suffer from chronic back pain more, and also when we're looking at acute sensitivity, so even how much pain you can stand, how much cold or how much, there's a test we do, it's called a cold pressor test. We ask the individual to put their arm in a bucket of ice water. And it's a really simple test we do in the psychology departments, not me. And you time how long the person can stand to keep their hand in the water, the cold water. And when they start to feel pain, that's the pain threshold. And then you say, well, keep it in as long as you can, and then that's their pain tolerance. But females are more sensitive to pain and they've got less tolerance. It's to do with their hormones, unfortunately. So the estrogen's got a large role to play in that. So so there's loads of things that can influence how we perceive pain. But one of the things that's really interesting is again from the little video, the conduction, perception, and then the final thing was facilitation and modulation of pain. And this is to do with our descending inhibitory pathways. Now this is, it's a really fascinating area of pain and pain research, and it's linked to the placebo effect as well. So once I've got our pain signals that are coming from the peripheral sensory nerve. We've also got that's terminating in the spinal cord. We have pain fibres from the eye that terminate in the pons. Then they transmit information up to the brain, we perceive pain. But then there's this pathway here called the descending inhibitory pathway. And that helps us control our pain response. And again, males have a stronger descending inhibitory pathway. So they can modulate and facilitate their pain better. And it's linked to estrogen again. So one of the key ways we do modulate our pain response is through release of endorphins. Now we've all heard of endorphins. Yeah. So endorphins are known as endogenous opioids. Opioids are the chemicals that we extract from the poppy. And we'll see that that's one of the key ways that we manage pain is through opioids and through morphine treatment. But in our own bodies, we manufacture chemicals that are really similar in structure to morphine, and these are known as the opioids. And I've got a few slides later on to explain how they actually work. And that's the poppy. That's the seed pod of the poppy. So again, I've got another tiny wee clip for you, how we suppress pain before we go into the drugs.
Sufi mystic Tim Cridland says the mind can block out fear and pain. To prove his point, he will lay on a bed of nails as a 2,500-pound car drives over him. Oh, it might sound crazy, but Cridland says stunts like this show people that nothing is impossible if you know what you're getting into. Today's demonstration was staged to promote the Evolving Times Expo scheduled for this weekend in Sacramento.
So that was a bit of a pointless video, but it was really to show that this descending modulatory pathway is really powerful. And not only in humans is it powerful, also in animals. And there's things called battlefield syndrome, where a soldier has been shot or injured in the field, and they don't realise they've been injured until they get back to their base camp. Same this, you can't really see this very clearly, but this horse had broke its leg. I know, it's a bit grim, isn't it? But the horse managed to complete the race. But again, it's to show that the descending modulatory pathway is really, really important in how we perceive pain. So before we go into the actual drug treatments, then I have a question for you. Sorry, this slide is just to show you the descending modulatory effect. So you all have heard of the placebo effect. So the placebo effect is really important in pain treatment. And 20 to 40% of people actually respond to placebo. So the placebo could be a sugar pill, it could be a sham injection, or even it can be just some kind of counselling therapy. Sometimes we think of that as placebo. Acupuncture as well, there's a whole controversy over that acupuncture actually works. And it's thought perhaps it works mainly through placebo effect. So when we're designing clinical trials to develop new drugs, we always have to compare the new drug against a placebo, but also against a currently available drug. So before we go into the pure pharmacology, I've got another question for you today. So here's a scenario. You've got a banging sore head, and you go into Boots or any other pharmacist, I should maybe say Boots. Who would buy Nurofen and who would buy ibuprofen? Now remember, both drugs contain the same active ingredient. Both contain 200 milligrams of ibuprofen, which is a non-steroidal anti-inflammatory drug. Is there any reason why you buy Nurofen? Anyone who does?
It's got caffeine in it.
It's good. What's that have to do? Marketing.
It's probably got caffeine in it as well. So
Yeah, well, Well, no, actually, both have got the same active ingredients.
Well, yeah,
These
but
you can get ones that have got
They probably
caffeine.
put caffeine in that as well, so it like
Yeah.
makes you feel better.
So you know that both are exactly the same, but the ones who buy Nurofen are not so daft as you look. So because what happens actually if they've done a study to show that people who actually believe that Nurofen were better for you actually had a more beneficial analgesic effect, and it's linked to the placebo effect, and it's called the psychology of belief. Quite often, if you believe something's going to be better for you, then it is. And it's not just it's all your mind. Actually, the descending inhibitory pathway clicks in, you get descending facilitation, and you get a decrease in pain response. So if you believe Nurofen's better for you, then you get the ibuprofen effect, but you also get a little added effect of a placebo effect. But now you all know that works. There's no point in buying Nurofen now, because have cancelled out your placebo effect. So there's also studies to show that how much you pay for a treatment can influence the benefit you get from it. So if you pay £100 for an acupuncture treatment, you want it to work, you're convinced yourself that it works. Whereas if you get it with a free trial, you're like, well, that was rubbish. And again, it's not just because you're making it up. There is the brain descending inhibition pathway does influence that. Okay, so we better do some drugs. So the next just 20 minutes or so, then we'll just cover some of the main treatments for these conditions that we spoke about this morning. Now, the pain can be treated via conventional medicines. So as independent prescribers, you'll be looking more at the conventional medicines and not the alternative medicines. But it's not to rule out that alternative medicines don't have a role in treating pain. So it's important just to know that certain alternative medicines, like I've got a little slide here to show you, acupuncture, medicinal herbs, relaxation techniques, hypnotherapy, ice, heat, and occupational therapy do have a role in the treatment of long-term chronic pain conditions. Some of them work perhaps through placebo effect, that could be debatable. Some actually have a physiological known role. For example, the heat, ice. These work by constricting blood vessels, increasing blood flow to the area, and taking away some of the inflammatory mediators. So they do have some kind of role. But quite often these are used in combination with conventional therapies. So if you've got a chronic pain condition, you might suggest relaxation therapy, but you would suggest that along with maybe a traditional analgesic drug. So I'm not going to cover these in any detail this morning. Have you heard of TENS machine? So again, TENS machine are thought to be beneficial for maybe long-term chronic pain conditions, so things like back pain, neck pain. The TENS, what it does, it puts a little electrical stimulus. You get little patches that you put on the body, and it's connected to an electrical stimulus, and it puts impulses through the surface of the skin to activate the nerve, and it's thought to trigger this descending inhibitory pathway as well. So I don't think you'll be using TENS machines for any kind of ocular pain though. So the analgesic drugs then, well, ones we're going to cover this morning are just the more commonly used ones, the non-steroidal anti-inflammatory drugs and the opioids. Again, there's not a lot of time this morning to get into much detail, so I'll just explain the basic pharmacological pathway and then some of the key drugs that we use and the side effects, the key side effects that you need to be aware of when you're prescribing these things. So opioids and non-steroidals, these have been around for a long time. And despite a lot of research in pain and analgesia, there's not that many new drugs have been developed or discovered. For neuropathic pain, we do use antidepressants and antiepileptics. And again, I've put a slide in at the end just to illustrate that. Now, these were discovered by accident that they have a beneficial effect for neuropathic pain. So, let's have a look at the opioids then. So, as I said earlier, the opioids are derived from the poppy, from the seed pod. So the seed pod's up here, you can see. And if we extract the juice from the poppy, where there's a whole cocktail of different drugs. Now, morphine is the main constituent of the poppy extract. But there's other things called, like, we have narcotine, papaverine, and codeine, which you'll have heard of. These are all natural extracts from the poppy as well. When we talk about opiates, opiates tend to be more the synthetic drugs. So if you go into the hospital and you're given morphine, they haven't been extracting the juice from the poppy to give it to you. What we do now is we manufacture a synthetic form of morphine in the lab. So we know the structure of morphine, so therefore we can manufacture it. We know exactly what dose you're getting and exactly what's in it. So that would be an opiate. And again, I mentioned there are endogenous opioids. These are the main one that we'll all have heard of as endorphin. Endorphins, we manufacture our own opioids. So there's endorphins, we've got enkephalins, and we've got dynorphin. So these are all manufactured in the brain, synthesized and released, and they bind to opioid receptors to cause their effects. So we'll see that in a little bit more detail. So the main effect of opioids, and the one that we're interested in, is that they are analgesic, really powerful analgesic drugs. But the problem with prescribing opioids is that they have many different side effects. And the whole list here is some of the different effects that they induce. So if you get into hospital and you're given a morphine, if you just come out of surgery, quite often it induces nausea. And I think it's 40% of patients respond or report nausea and vomiting after being given morphine. So it's not particularly beneficial if you're already in pain and not feeling particularly great, and then you feel sick as well. Sedation, euphoria. In some cases, sedation might be beneficial if you come round from surgery and you're a bit distressed. If you get a morphine type drug, it can induce sedation and have a calming effect on the patient. But it's not particularly beneficial if you're on drugs and you have to drive to work. So there's a balance between when these drugs should be given and what dose, that kind of thing. But other things, respiratory depression, the main cause of overdose of these things when they're used recreationally is respiratory depression. So the person just stops breathing. Can lower blood pressure, cause constipation, itching, and again, addiction and tolerance. We'll all be familiar with how opioids are highly addictive drugs, and they also induce tolerance. When we say tolerance, what we mean is you need an increased dose of the drug to induce the same effect. So you'll have heard of perhaps like terminally ill patients who have to keep increasing the dose of the drug to get the same level of pain relief. So that's a consideration. And the other thing, the contraction of the pupil. So if you're familiar with this, that one of the diagnostic criteria they use if someone comes into accident and emergency and they've overdosed, you look in their eye, and if they've got, it's called a pinpoint pupil. So that's a response to opioids. And even if you shine a light in their eye, or if it's the pupil doesn't react the same, or if there's a darkened room, the pupil should dilate. So there's no response. So that's one of the diagnostic criteria, which is different from if you're taking amphetamines or cocaine. What happens then? Or ecstasy? You've got a big giant pupil. Or if you're in love, you get a big giant pupil as well. So, so if you're looking at a patient's eye, it might be love. Okay, so some pharmacology then. This is the most interesting stuff for me, maybe not for you. So we've got pharmacology here. So opioids work by binding to a particular receptor. So morphine binds to these receptors, but so to endorphins as well. And there are 3 receptors. There's the mu, delta, and kappa receptor. So what happens then? Why does this induce a pain relieving effect? Why are opioids analgesics? Well, the little cartoon here, I think it's just a simple illustration. So this is a nerve here. In a normal situation, when the nerves are activated, you've heard of hyperpolarization of the nerve. Calcium influxes into the nerve. Cyclic AMP is increased, And this causes action potentials to be generated and transmitted. So this would be a normal activation state of the neuron. But if we take opioid drug, or we release our own endorphins, it binds to the opioid receptor on the surface of the cell. This turns off the calcium channel. It causes potassium ions to flow out of the cell. There's a decrease in cyclo-KMP levels. Now all these things combine together to cause a thing called hyperpolarization. So the cell, basically the cell is shut down. It's inhibited the cell function. And that has the impact of closing down the nociceptive input to the cell. Okay? So simplifying it a little bit, but basically it causes an inhibition of neuronal activity when we take opioids. So where are the opioid receptors? Don't expect you to learn or memorize or know all these. The main thing that is important to know is opioid receptors are found in the brain, they're found in the pons and the medulla, they're found in the spinal cord, they're found in the peripheral nerves, they're also found, there's a high innervation of opioid receptors in the gut. So have you ever heard of the gut being called the mini brain? No? It's quite nice. So think about if you ever go to give a presentation or you're nervous, you get that feeling in your stomach and you get an increased, maybe I shouldn't get into too much detail here, but you get you have the feeling that you need to maybe go to the toilet as well. That's all linked to our opioid receptors and our release of our endogenous endorphins and opioids. Because if you remember, one of the side effects of taking these drugs is constipation. So there's a large innervation in the gut of opioid receptors and function. So anyway, the mini brain remember that, the mini brain. So yeah, so the receptors are found in all different locations within the body. So if we take an opioid type drug, it not only blocks the pain response, but it can also cause these adverse side effects too. So the next few slides I put in is to show some of the examples of the key opioid type drugs that we would prescribe or that you can get on prescription. So I'm not going to go through them all in a huge amount of detail. So the opioids are known as agonist type drugs. Agonist means when they bind to the receptor, they cause an activation. An antagonist, when we refer to drugs, is something that would bind to the receptor and stop the receptor activation. So it's the antagonists for the opioids are known as naloxone and naltrexone. So if someone is overdosed on opioids and goes into the accident emergency again, they can get an injection of naloxone. Naloxone is an antagonist that blocks opioid receptors. So in some cases, I think there was quite controversy recently when some health boards were giving out naloxone injections to drug addicts just in case they overdosed. So they could keep them in their bathroom cabinets in case they needed them.
How are they going to inject them if they're overdosed?
Yeah, so it's a bit controversial. So the next few slides, just some of the key opioid type drugs: morphine, methadone. So the information's on the slides. What you need to know about these. Codeine. So the codeine's the ones that we can buy over the counter. In fact, most people, I'd assume most of you will have had some kind of codeine formulation at some point. Quite often you get them with paracetamol. So the cocodamol is the main formulation for this. The one, if you get them from your GP though, is a bit stronger. So it's 8 milligrams of codeine with 500 milligrams of paracetamol. Pethidine is another commonly used opioid. It was quite commonly used during labour, for women in labour, for labour pains. It's a bit more sedative and it's got a shorter duration of action, so that was why it was used for that purpose. And heroin, the drug name for heroin is diamorphine. So doesn't tend to be used clinically so much. Sometimes it's used for cancer pain or for suppression of cough, but it's not really routinely prescribed. And fentanyl is more for chronic pain, where you get fentanyl now in little patches that slowly releases the opioid through the skin. Okay, so I think the next class of drugs then, just in the last few slides, is the non-steroidal anti-inflammatory drugs. Again, I don't want to go into I didn't want to get into too much detail. I don't have any time now, but you've got a document in your pack that covers the non-steroidal anti-inflammatory drugs in some detail, and it lists some of the key drugs that you might use. But the non-steroidal anti-inflammatory drugs are a really broad class of drugs, and you can see from this slide here, there's a whole list of different non-steroidal anti-inflammatory drugs that can be prescribed. The key ones, aspirin, that was the prototypic one that was discovered way back. Well, it's been used for hundreds of years, but in late 1800s, the drug company Bayer first manufactured aspirin. So it's been going around for a long time. Paracetamol, ibuprofen, diclofenac. So you've probably heard of all these types of drugs. So how do they work then, and what are they for? So the non-steroidal anti-inflammatory drugs, as the name suggests, are useful for treating inflammation. They can reduce the levels of inflammatory mediators at the site of damage. But they can work at the site of damage where the tissue's been injured, but it can also work in the brain as well, where they inhibit the release of prostaglandins. So they have a whole range of different functions. They're anti-inflammatory, they're also analgesic, they can be antipyretic. So you'll have heard of taking paracetamol in cold and flu formulations, and that's because paracetamol reduces temperature, body temperature. And they're anti-endotoxic as well. They don't produce any tolerance or dependence like the opioids do. Topical or oral for ocular pain. And again, there's a couple of tables in your document there showing some of the main types of non-steroidal anti-inflammatory drugs that are used for ocular pain. So here's a little pharmacology pathway then, which is important. So how do the drugs work? They work by blocking an enzyme known as cyclooxygenase. So there are two types of cyclooxygenase. There's cyclooxygenase 1 and 2. We can split these into almost like a good and a bad enzyme. COX-1 is an enzyme which is known as a housekeeping enzyme. It's responsible for production of prostaglandins that we need for everyday bodily functions. So they keep blood vessels dilated. They're important for kidney function and also just general production of prostaglandins in the brain. COX-2 enzyme, on the other hand, is an inflammatory enzyme. It's known to be induced in response to tissue damage and injury and inflammation. So when we take a non-steroidal anti-inflammatory drug, what we want to do is inhibit the production of prostaglandins. We want to inhibit mainly COX-2, so that the bad enzyme. We don't want to inhibit COX-1, because then that's when we get the side effects associated with these drugs. Okay? So the pathway we've got here, phospholipids make up the structure of the cell membrane, and they're converted into this substance known as arachidonic acid via the action of phospholipase A2. Arachidonic acid is then further converted to prostaglandins, leukotrienes and thromboxans via the action of these two enzymes, cyclooxygenase and lipooxygenase. If we take a non-steroidal anti-inflammatory drug, it blocks cyclooxygenase and therefore blocks the production of prostaglandins to get reduction of inflammation. Okay. So they say some drugs are more preferential inhibitors of one enzyme over the other. When we look at aspirin and some of the older drugs, they block COX-1 and COX-2 with equal efficacy, it's called. So that means that they cause anti-inflammatory and analgesic effects, but they also have quite a large number of side effects. Some newer drugs were developed that were preferential inhibitors of COX-2, so they preferentially inhibited the bad enzyme. So these are known as diclofenac, meloxicam, rofecoxib and celecoxib. So I'll just finish up then, but there's a couple of slides just showing some of the side effects of the non-steroidal anti-inflammatory drugs. You've probably heard of this before as well, that they do tend to cause a whole range of problems. One of the main side effects with non-steroidals is that they cause ulceration and damage to the stomach. So if you take a paracetamol or a non-steroidal anti-inflammatory drug for a day or two, it's unlikely to have many side effects. But if you're on ibuprofen for a more chronic injury, then you can get some kind of serious side effects, which are shown here. It causes erosion of the gut lining and causes ulceration in the gut. So this is quite a common side effect with non-steroidals. So when you are prescribing them, you have to take into account the patient background, but also the length of time they're going to be on these drugs and whether they're going to have any side effects. Okay, so I'm aware that we're coming up to the time. So the last couple of slides were just paracetamol, which you'll have heard of. Acetaminophen is the name it's called in America, or Tylenol, if you want to know the difference between the brand name and the generic drug name. So Tylenol's the brand name in America. So paracetamol, these are really useful drugs, but again, the side effect associated with these, or paracetamol, is liver toxicity, which is another consideration. Okay, so the final slide was just about the treatment of neuropathic pain. And again, I don't have time to get into details here, but just to let you know that there are other kind of newer drugs available for treatment of neuropathic pain. And if you go to the GP, or if you've got post-herpetic neuralgia, things like that, or neuritis, they'll be prescribing these types of drugs and not the opioids or the non-steroidal anti-inflammatories. So the antidepressants and anti-epileptics are more beneficial for neuropathic pain. Okay, I think I better finish here. We'll be needing a break. Okay.